What is adult congenital heart disease? To understand the population of congenital heart disease, we have to focus on three words, which is incidence, mortality, and prevalence. And the incidence in 1952 was found to be around three newborns every 1,000 live births. And the incidence changed considerably, and now in 2002, the incidence was found to be 8 to 10 newborns every 1,000 live births, which means 1% of newborns has a congenital heart disease, making the congenital heart disease the most common congenital anomaly in newborns. The major contributor is VSD, ventricular septal defect, and then there is ASD, PDA, and so on. And among the most critical congenital heart disease, tetralogy of Fallot is the most common. And as you can see, the incidence and the mortality in congenital heart disease is different among countries, and the one with the higher GDP have the lowest incidence, and the one with the lower GDP have the higher mortality. So as a result of this progression in technology and in surgery, the overall survival of patients increased, and now you can see late era, which is the current era, 93% of patients with the congenital heart disease are expected to survive up to 15 years of age. And if we stratify these results according to the severity of the congenital heart disease, you can see that in most severe cases, severe two-ventricular congenital heart disease, 90% of patients are expected to survive 15 years of age, and among single ventricle patients, 75% are expected to survive 15 years of age. So here you can see which is the survival expected by kids, by newborns with a congenital heart disease, and this is 1980, only 40 years ago, just to make you understand which is the improvement in the last 40 years. And this is in specific, you see the improvement is evidence also in VSD, in tetralogy of Fallot, in transposition of the great vessels, univentricular heart, you see here, and hypoplastic left heart syndrome. They were expected to die in few months, and now they are expected to survive into adulthood. Aortic valve, tricuspid valve, for sure pulmonic valve. I'm not going to speak about pulmonic valve, which is pretty common, I mean, since at least 30 years. I'm going to speak about endocarditis, because endocarditis incidence is 2 times higher than in general population. And even if this type of endocarditis is really disruptive, so many times we can see patients with tricuspid endocarditis or pulmonic valve endocarditis with many abscesses or many vegetation in the pulmonic valve. The mortality is anyhow lower than in the non-congenital population, since our patients are younger, usually, and the endocarditis is most often on the right side and less frequent on the left side. Endocarditis represents 2 to 4% admission of to ACHD service, and in these 5 months we already had 1 endocarditis, one that went surgery after was a Ross procedure. After a Ross procedure, and mortality is around 7%. And risk factors are repetitive cath lab procedure, which is we use a lot of cath lab in congenitals, pacemaker leads, implantation, prosthetic material, or syndromes. I mean, many of our conotruncal patients have DiGeorge syndrome, which predisposed to endocarditis. Then there is the chapter of heart failure, which is probably the biggest in congenital heart disease, in adult congenital heart disease. Heart failure has a critical impact and is the major cause of death, and the mortality rate is 25% for many causes. There are 2 main groups leading to heart failure. One is having a systemic right ventricle. So the right ventricle is weakest compared to the left ventricle, and many congenital patients have a systemic ventricle, the right ventricle. And those patients are going to experience heart failure in 3 decades to 4 decades. So there are many patients with congenitally corrected transposition of the great arteries or transposition of the great arteries who underwent atrial switch operation, who are coming back. And they are coming back with heart failure and requiring or MCS or transplant. And then there is this huge population, as I told you, 70,000 people with a single ventricle physiology who are coming back with heart failure because the single ventricle usually is prone to dilate and the AV valve is prone to be regurgitant. This is the mortality in the waiting list for transplant, and you see the mortality is different according. So all these patients are needing heart transplant, all these patients are in heart failure, but in the waiting list, being a patient with the tetralogy of Fallot or being a patient with the Fontan carry a different risk in the waiting list. But since in 2018 the rule for transplant changed in the USA, the mortality in the waiting list reduced consistently. And which is the expected survival in those patients? Here you see that the mortality is higher in the perioperative period because they are, for sure, they are more complex, but the survival after 10 years is much higher than the survival expected in non-congenital patients.